So I want to thank all the presenters for some very important and complex and new and emerging information. And, in as much as this is within the context of screening, it would be important to kind of tailor the conversation in that we seem to have a lot more emerging information to some of the other presentations we've had. Could you help us in understanding what's the biggest opportunity for integration of analysis of these types of dynamics in prospective screening activities? Does anybody want to take that on? Is there some particular? Yeah.
The marker of metabolic dysfunction that can be treated now. So like, go for it. And as I mentioned, AGA already has an algorithm for working up steatosis as an incidental finding. And basically working through the algorithm, what the first step is trying to evaluate for liver fibrosis, because it's really liver fibrosis that's going to indicate a person is on the path toward progressive liver disease. So I think in that case, it's really just, it's just really right there. I mean, there are algorithms to detect it that work effectively, and it's very easy to link your radiology report to the hepatologist. Like so that's kind of, I would say, the lowest hanging. A question I have is, where are we in terms of image analysis to get information about these various fat depot sizes and how to do that? Because I would love to have information about subcutaneous fat and visceral fat and liver fat and pancreas fat and kidney fat, but I don't know enough to know what. Are we there? Do we have the software to do that, or does that require more development?
So one thing that I might suggest is that, as opposed to calling it incidental findings, I think this is some kind of immunometabolic consequence.
Yes, that's what I'm trying to convey.
Okay, so if it's tobacco-related immunomodulation, whatever, metabolic modulation, it would appear that studying these diseases within the context of what we've heard, where there's augmentative impact of the fat dynamics on top of the progression of some of the other more established diseases. And we've heard about how interconnected all these things are. If we stop kind of pulling these things out into different polarized bodies of science and try to study the integration and how they kind of come together relative to improving.
Yeah, no, I was talking to Jeff before, and let's see, I can't remember what term he used, back engineering, I think, reverse engineering. I suggested that what we do is we find the diseases that improve when you treat with GLP-1 receptor agonists, and then you use that as a way to figure out what metabolic syndrome really is, because we don't really know.
I think the answer to your question is absolutely yes, Dr. Huang. There are so many AI tools available that can measure quantitatively, report fat distribution, the abnormal adiposity, sarcopenia, combined sarcopenia and fat. So the technology is there. It's this kind of meeting, the awareness, the guideline, and bring it to patient care with FDA approval. I don't think there are FDA approved products, to my knowledge, in this. And I'm just gonna bet once we get this out, people may, the general public may love that part a lot more than coronary calcium and long nodule, because they look at, most people like to see their fat go down. If you tell them that you have this much of visceral fat or fat around your heart, it gets their attention. So that's the kind of discussions that we needed to have for this meeting.
And some of these drugs, they just drive the fat out of the liver. Like if you see serial MRIs I mean, it's shocking to see the decrease in steatosis on these drugs.
Well, well, developmentally, much of the field of immunology, which was very confusing, even more confusing 10, 20 years ago, was kind of directed towards things like C-reactive protein.
Yes,
What is C-reactive protein?
it is curious.
So that really, you know, the short answer, I think, is that it's a surrogate of inflammation activity. Instead of you calling stuff fat, your fat really equals some kind of metabolic, immunometabolic perturbation.
Yes, it's some kind of disorder. And
So-
we can identify it with these drugs. As I say, I think Jeff's idea of reverse engineering the definition is quite a clever one.
Well, if you can map it back to specific, you know, metabolic pathways and stuff like that, it might allow us to move it forward more rationally and with less objection, because people are just confused by this fat, that fat, you know, what other fat. If it could be, you know, I think with a lot of things, we're getting back to fundamental biology. And and it clearly is driven by fundamental biology. And if we could relate it to that, it could cross over between cardiovascular disease, pulmonary disease, cancer in a much more, I think, adaptive way.
Yeah,
quick-
I think
So-
these drugs are going to be very good anti-inflammatory drugs. I think that's really what's.
Yeah, GLP-1 definitely. I was telling folks that to cardiology, it's the best next drug after statin, and it's proving even more than that. Susan, you go ahead.
So everything that you discussed is ongoing. There are molecules. Adipose tissue is the largest endocrine organ in the body. It secretes more than 100 factors, some protein, some transport protein, some endocrine factors, including adiponectin, which has been put, you know, is probably our best candidate for a marker, but it's complicated because of its multiple molecular forms. So it's not easy to measure, but it can be done, and that can be done as well. In terms of prediction and finding, not just, there's good fat and bad fat. We cannot tell from the mass. We have to look at it more carefully. When I get fat samples in my study and we look at them and the whole world looks at them, everybody gets this finding that dysfunctional fat from people with the worst metabolic syndrome is fibrotic. It's filled with more and more macrophages. Those macrophages are more toxic in that they are secreting inflammatory cytokines. This instigates the fat to release very high concentrations of fatty acids, and the way that can be toxic to the other tissues and are deposited there. There are clear mechanisms, both at the physiological and at the molecular level, which controls its adipose cell is only 50% of the cells in the fat. There are multiple mechanisms, like any other endocrine cell, to control how much is made, how much is degraded, and how much is released.
So from a functional perspective, could you and your colleagues kind of come together and create a logic tree about, in routine lung cancer screening, what would you want a radiologist to characterize for you in probably a research-directed report at this point in time? Is that something, Dr. Mechanick, is that something that would be useful, or
And
is there something else that
being-
could be done?
That's what we're doing.
Right. So let me just repackage this question a little bit. It seems to me that the real question is about early detection. And the reason I'm focusing on that is what's actually the problem in healthcare now? And the problem in healthcare is that we have so many chronic diseases. We have a multi-morbidity model. And despite all of the information that we have in the growing and emerging technology, if you look at the prevalence rates, they're getting worse. Now you can parse them out into different subpopulations, but we're actually not doing a good job. And we need to be able to leverage primordial and primary prevention better. Dr. Fuster will be speaking on primordial prevention in 2 days, I guess. But is this actionable? So what? So what if we detect these things earlier? You got to have an action. And in order to have an action, you need a model that can direct it. Right now, our models are that there are 3 primary drivers for these chronic diseases: genetics or molecular, environment, and behavior. So we have tons of data where people, the Kira paper, New England Journal, December 2016, where patients were at high genetic risk for cardiovascular disease, but when they adopt a healthy lifestyle, and this is information from the electronic health records, they had a risk reduction of about 48%, which is huge. And that's the environment and the behavior. We need to have structured lifestyle, but in order for that to happen, and again, you reverse engineer it back, what would make this system work? It would be early detection. That's the problem. Now we get to your point. There are so many images that are done that there's a waste of information. And now embarking on an age of Internet of Things and artificial intelligence, we just published a couple papers on digital twin technology with complete remissions of diabetes in a multi-center study in India. When you have all of this information at hand, particularly with AI-enabled technology, now you get this information. And you don't have to have the humans ask those individual questions. The information's there, it's curated, and you have actionable directives, basically. I think that's where we're heading. I think that's the future. It's a future that we're not going to be able to avoid. And I think that conferences like this, which position the technology for early detection, are going to be valuable. So
Can you elaborate on digital twin?
sure.
I guess
Sure. So we have 2 papers out. The first paper is in endocrine practice, actually looking at NAFLD, but MASLD. And the second paper was in JACC Advances on Hypertension. Digital twin technology did not originate with healthcare. It originated with aerospace science and NASA. It's basically a way to virtually represent something in the natural world. But for humans in healthcare, what we did in this particular study is patients, and full disclosure, because I consult for Twin Health, but it was on my slide. But humans wear a continuous glucose monitor, they wear an accelerometer, they have an electronic scale, and they have electronic hemodynamic monitoring devices. The information goes into an Internet of Things construct to proprietary artificial intelligence, and then with 24/7 bot coaching, patients are now able to change their behaviors in what they eat. And they change their foods based on postprandial glucose levels. Their weight comes down. We had a 78.7% complete remission in diabetes, defined as 3 months off all medicine, normal numbers, in a multi-center trial in India. And the Cleveland Clinic paper is just ready to be submitted now.
3 months?
3 months. So that's the current definition of a complete remission. So at some point during 1 year, 78.7% of patients enjoyed a 3-month period where they got off all their diabetes medicines and had normal A1Cs, continuous glucose monitoring, fasting blood sugars, et cetera, based on digital twin. That's off all medicines. And they were on a lot of medicines, including insulin, and bearing in mind that the Asian Indian population, the diabetes phenotype described by V. Mohan and Chennai is very different than in Caucasians, right? You have a beta cell hit, you have diabetes at lower BMIs, even though there's insulin resistance, you can get fibrocalcinosis of the pancreas, you can have decreased beta cell reserve. So there's more of a postprandial hyperglycemia hit than there is an insulin resistant hit. So everything I just said, if you're thinking, you can realize you can detect this with imaging. And what you're going to hear when Dr. Fuster speaks is he's going to be a proponent. He's going to talk about his PESA stuff, and I want to steal his thunder, but he's going to talk about how imaging is going to facilitate a lot of this. Imagine if you had a patient with completely normal numbers and completely normal anthropometrics, and you had imaging information that already showed pathologic, however you define it, as a statistical based classifier, pathologic ectopic fat, pericardial, whether it's muscle, whether it's in the pancreas, you're now going to initialize some action. The action doesn't have to be pharmaceutical.
I agree.
It doesn't have to be pharmaceutical. So it's going to be cost effective. So we need our infrastructure, socioeconomics improved so that we can get people into a medical gym, have them see a sleep hygiene person, see a dietitian, get them to the right consultants. And in fact, if you think about the socioeconomic piece, by bundling all the economics here, you're using, and I hate to say the word incidentally, but incidentally, you're using that information which would have been thrown in the garbage, all that extra information about bones and about sarcopenia that you would have had on those images. Now you can use it and you can profile a patient and risk stratify them at an early age. And when I say early, I mean, you're talking about teenagers, 20s, maybe even school children. And in fact, I don't know if you saw my last slide, the problem with science fiction is it underestimates the future. That really what's going to happen is this is going to be maternal health and transgenerational medicine.
Okay,
Where we're even starting.
so I think this is phenomenal, but we got to get there. And right now, this year, there's going to be a few million thoracic CTs done. And the only thing I know about this is that there is no standard reporting of fat in a CT study. And my question as a simple type of person, when we hear about all the primary care and all these other challenges is, how do we get experts to help us say, here's what would be the snapshot? Because this is all going to be longitudinal screening over year after year. How do we get something done now that will potentially help us deconstruct all these dynamics to allow what you just outlined to happen?
Well, David, Jim, I'm going to weigh in here. We take actions. As you know, 3 years ago, I started with Claudia and David. Now we have an FDA cleared auto bone density AI that's applicable and it's being installed in Mount Sinai and will give a report without you doing anything. It's just.
And some other health information we don't report. And we have a tremendous clinical burdens. Literally, we can only afford a couple minutes on each study.
Yep.
So this kind of help is what we needed. And we are very aware of all these problems. I would just come back from our International Skeletal Society meeting, and there are so many talks on visceral fats and muscle fat. And also there was a study proposed, was interesting. I didn't know they were looking at all this AC joint or near the heart soft tissue calcifications that were wrongfully attributed to heart calcifications, and how to use AI to increase the sensitivity of that. So we are all very well aware of that, but all this work are done in the research arena.
Yeah.
There was study that done with AI, they can adequately diagnose or pick out patients who are risk developing metabolic syndrome very accurately from that group from University of Wisconsin. It's all there, but we need a tool that be fast and
Practice.
exactly.
So what I just heard you say is you guys are volunteering to be in a subcommittee to urgently map
Yes.
a profile of immuno metabolic factors that should be routinely recorded on a thoracic CT.
We will be actually circulating after this was, as I said, a
No, but,
draft
uh,
that we would need your help in weighing on and forming it and shaping it to a writing group, white paper of some sort that would actually put in, in front of policymakers.
Would that be worthwhile? You're
Yes,
the
that's
experts.
Our radiology report is going, is our standardized reporting, and you can just add a category with all the numbers and stuff there. That's where the direction going.
Also, I don't know if it would fit in this white paper, but it kind of picks up on something that Dr. Mechanick was talking about. Certainly, there are alternatives to pharmacology, but I've got to say, as far as our patient population of liver has been concerned, like we've been advocating for weight loss and more exercise for decades, and the impact on disease has been not what we would hope for. So I think one thing that would be really helpful is if people thought about how things are paid for other than pharmaceuticals. And I don't know if you could work this into the white paper, but I think a huge hurdle is that we need physicians to be able to write prescriptions for gym memberships and for interventions with personal trainers. And I think that if we got that kind of cost flow going to support non-pharmaceutical interventions, we'd find that they were a lot more effective. Whereas we're stuck currently with this situation in medicine where you can write a prescription for a drug and it's going to get insurance coverage. You want to write a prescription for somebody to go to a personal trainer. That's a hurdle that we really haven't addressed. So how we can get that insurance piece to cover the kinds of interventions, I think that is really a critical part of solving this problem.
So that's a very important point. And what I would point out is in the commentary that was published with the revision of the U.S. Preventive Services Task Force assessment of COPD as a screening tool, the editorialist basically said that exercise and these other interventions in COPD is very important, but there's not a single trial of quality in the literature that gives us an inkling of whether it works or not. So I think the impetus to take these ongoing cohorts and to start to pilot some of these things to get support for what you just said, it seems like an urgent first step.
Yeah, I really think it is.
Yep.
Working out a pay line for these lifestyle interventions, especially as they relate to physical activity, I think is really critical.
One last question.
It's very nice if we can quantify, for example, body composition, but that's only one step. For example, with body composition, you have, for example, total segmentator and all those, you got many, many measurements, but we don't have standardization of what measurement we should be using, because before, for example, we had T4 levels where we had just an area of muscles and stuff like that. So we can do a lot more, but we need to know what should we measure, what are the reference values, what is abnormal, and what should be then the management recommendations. And as, for example, we have that L1 level versus L3. We checked that in our screening population, and 30% doesn't have L1 because we are pretty good with our dose limits. So we really try to just stick to the entire lung only. So I think we need to work together to get reference values and standardization of levels where we should be measuring on a thoracic level.
Excellent point. I think we are working on that at thoracic level. Hopefully next year we'll have solid information to share. But what you just said is applicable to everything else, to bone density reporting, to muscle reporting, body fat, liver fat. One of the questions I wanted to ask you, Andrea, is if somebody goes on a fasting, like 3-day fasting, what would happen to their fatty liver picture? Would that go down?
Oh, it absolutely.
Yeah, so that's,
but it's really interesting that in studies that have been done where people are not told to fast, where people are just coming in for scans, when patients are followed longitudinally, it's a remarkable stability in the value. So in theory, yes, it could fly all over the place. It could make a difference if you had a burger
Or
and
a
a shake
big
that
meal.
morning. But in practicality, when I've seen the CT data over longitudinal measurement, it's been remarkably stable. But that's really something that I want to look into, because one of the secrets about liver fat is there's a theory that when liver disease progresses, the liver loses its ability to store fat. And whether that you could actually document longitudinally, and what happens to cardiovascular risk and what happens to markers of cardiovascular risk. I've never been able to find information about, and it would be a great.
Yeah, that's a hot topic. The same thing for osteoporosis. We found those people who have higher osteoporosis, lower bone mass, have higher coronary calcium, independent of the traditional risk factors. An interplay between bone metabolism, calcium metabolism, phosphates, and what happens in coronaries.
Yeah,
So
but I'd like to come back to that because Rosemary suggested we need to have some,
Extended.
reference for various things in various populations. Dr. Yankelowitz has brought this up a number of times, and it's an equity issue. Because when you say you want to have reference information, and it's going to be on a population health, for a tool to be disseminated, it means that you have all the vulnerable populations, all the diversity of age and gender and sex, and so that this is why we need to step back and start approaching population screening in a much more rigorous fashion so that we have a way to acquire that data.
Absolutely.
Because the technology is going to change
Absolutely.
there. And so this is a key factor that has been underappreciated. It's not a one-off thing, and it's not in a population cohort of 10,000. It's in the whole population. So how are we doing on time? I think we have 4 minutes. We will finish 4 minutes early or something like that.
Shemesh?
We'll keep it under 4 minutes.
Yeah, I just, when you are going to put it in the report, all these wonderful findings of a new chronic disease that you see, and I'm, as the treating physician, asking the question, what do you want me to do with this? So this is very important because now we are in the first stage of detecting the disease, and then we'll have to learn the natural history of the disease and how we can change it. It means to say the treatment. I think that the coronary calcium is the model, and it took 30 years to answer all these questions and to give the physician that get the answer, and he knows what to do with it. So it's really wonderful.
Yeah.
Things are, you see these things, but how do you think about specific treatment? All of them are sure a healthy lifestyle and changing the diet. It's things that are normally and act, but when you are going to report on some kind of, what kind of obesity I have, what to do with this, what's the differences, how to treat the patient. I think it should be very, very careful when you are going to send the physician all these findings in the moment that he doesn't know what to do with it.
Your point's very well taken, and I think we have to conclude here. But that's exactly the task in front of us. And I think there's
And we will be
agreement.
working on that. And I think hopefully the calcium score will not be the role model. It took 30 years. We have more evidence. These guys, endocrinologists and, GLP-1, saga has created a lot of positive signs, but you're absolutely right. No diagnostics tests or examination saves lives. It's the intervention after that, what to do with it, and care pathway will be part of the working group that will need your help and everybody else. Thank you so much.
Thank you for the panelists, and thank you for the participation.